Morning.
Good morning.
How are you? Well, it's 8, but I'll wait for a few more people to join. Hey, Max.
Morning, sir.
All right. I think I'll get started. All right, you guys see my screen?
Yep.
All right. So this first case is a 7-year-old guy who presented to his primary with an enlarged neck mass. Ultrasound revealed a 2-centimeter left cervical level 5 lymph node, and so they did a core biopsy. This was from an outside primary, outside of our system, so I had no history on this guy whatsoever. And this is the core biopsy that I got. So when I first see something like this, I go through like varied emotions. I see something like this where I don't immediately recognize what this is. And I think, oh, this is exciting. This is going to be an exciting tumor. But then if I still don't know what it is after about a minute, then I'm like, fuck, I don't want to have to work this thing up. So, and this is kind of, those were the emotions that I kind of had with this case. Anytime you have anything that's solid, falling apart in areas, the differential is just so big. And if it's someone that doesn't have a history of something and you don't really have access to their medical record, and so you can't really look up more to give you hints about what this may be or may not be, then it just becomes very, very difficult. And you have to be lucky, because I don't like relying on immunohistochemistry, because sometimes it can really send you down the wrong path. So what you do in a case like this, or what I should say I do, is I go on high power and I try and look for clues. So with something like this, the differential is wide open. Melanoma, lymphoma, carcinoma, sarcoma, it could be absolutely any one of those. When you start seeing a lot of discohesive cells, I think melanoma, lymphoma become higher in the differential. Obviously, it can be a carcinoma as well. Breast cancer in particular can be very, very discohesive, especially that on FNA, because even ductal carcinomas often have a single cell pattern. Now, this has a lot of inclusions, and so a lot of times in core biopsies, especially if you see a lot of them and the nuclear detail isn't that great, you have to worry that it's an artifact. This does not look like an artifact. These look like true intranuclear pseudo-inclusions where the what's inside the nucleus is the same color as the cytoplasm. So then what's your different melanoma? It's still in the differential. So if you're thinking melanoma, then you start looking for pigment. A lot of mucosal melanomas don't have pigment, but most cutaneous melanomas, when they spread, you should find, or you can find, some pigment. But then what's wrong for melanoma? There aren't really prominent nuclei. You don't have to see that, especially because some of these nuclei are a little convoluted, maybe nevoid looking, but there are a lot of inclusions. And so something else you need to think about with a plasmacytoid looking tumor with a lot of intranuclear inclusions is that this is actually a plasma cell neoplasm. In this case, it would be an extramedullary plasmacytoma, because it's not in the bone. It could be a manifestation of myeloma. And if these are truly plasma cells, now here's some prominent nucleoli. But if these are truly plasma cells, then these are Dutcher bodies. And Dutcher bodies are more often seen with IgM producing tumors. You see them absolutely in plasma cell neoplasms, although more often you see them in like lymphoplasmacytic lymphoma, because those are the ones that are often IgM. IgM is the biggest immunoglobulin, and so those can't make it out of the nucleus sometimes. That's why you see Dutcher bodies instead of Russell bodies, which are more often like IgG, IgA. But you definitely do see that. So I didn't really see any other clues here. So I kept looking. Here's the other core. We always send, when we get these needle cores, I started having our techs separate them into 2 blocks and do unstained on both of them. That way we have 1 block that we can kind of save if we end up sending it out for molecular testing or something. So this other core, same thing. You don't see keratinization. There's no gland formation. I didn't see any pigment. Even at this magnification, you still see a lot of the intranuclear inclusions. And then I started seeing a shitload of plasma cells. So when you have definite, clear, good plasma cells, and then these kind of merge with what looks like a plasmacytoid looking tumor that has possible Dutcher bodies, you should really think that this actually is a plasma cell tumor. And when you think of that on the H&E, you have to be careful about your immunostaining, because if you just do the regular workup for lymphoma, melanoma, etc., you are going to miss a plasma cell tumor, because these would be CD20 negative, typically CD45 negative. So if you're doing kind of a general lymphoma, sarcoma, etc. panel, you'll miss them. The other thing to think about, if you have something that looks like a hematopoietic tumor and you do your CD20, CD45, everything's negative for keratin, S100, etc. Don't forget about myeloid sarcoma, so basically AML on tissue, because those will also be negative for those markers. So you'd want to add a CD34, CD117 to get those. So with all of this, I thought it could be, look at all these plasma cells. I thought that this could be a plasma cell tumor, but I still thought it could be anything else. So here's CD138. So we'll talk a little bit about CD138 more, but we know there's plasma cells in here. So the question is, are the tumor cells plasma cells? I think the tumor cells are predominantly negative, but some of these cells that are staining look a little big. So are these just the mature plasma cells? Are some of the tumor cells staining? I think it's hard to tell. There's actually quite a bit of staining. It's not strong and diffuse, but there's quite a bit of staining. And again, CD138 isn't entirely specific, but it will help you highlight the plasma cells. So I thought this was probably predominantly negative, and it's those perivascular plasma cells that were positive. I did kappa and lambda too in situ hybridization. That was negative. So here's keratin, CKAE1, AE3. I usually do a couple when I have a workup like this, because one can be negative and one can be positive. So this is CKAE1, AE3, totally negative. And then here's CAM 5.2. So CAM 5.2 actually is staining some of these cells. Most of it's negative, but some of them are positive. So what does that mean? CAM 5.2 is good for neuroendocrine tumors, more so than CKAE1, AE3, and oftentimes you'll get like a dot-like staining. But, I think sometimes people take a little bit of focal staining and consider it positive. I get worried when it's a keratin that's saying that this is a carcinoma based on this little keratin staining. So I thought this was probably negative, but I wanted to see the rest of my stains. And here's S100. So that makes it a little more helpful. So this is strongly S100 positive. So does that mean it's a melanoma? Not necessarily. It could be a pecoma. It could be a myoepithelial carcinoma that's very plasmacytoid. Now, I don't think it's that. Those usually myoepithelial carcinomas would be more keratin positive, and this was not really. So let's look at the other melanoma markers, because I got them all up front because that was pretty high in my differential along with the plasma cell neoplasm. This is SOX10, strongly diffusely positive. And then getting to melanoma specific markers, this is HMB45. I usually do HMB45 and melan-A, and HMB45 is usually the worst of them. And this is positive with this granular cytoplasmic staining. So now it makes sense with the focal patchy, nucleoli that are prominent, intranuclear inclusions, a met to, the lymph node in the neck, positive HMB45, strong S100 SOX10. So this is metastatic melanoma. So I have showed you guys so many melanomas. And I tell you that I've told you before, we see a lot here, many more than I've ever seen, percentage-wise of my practice than any other place I've ever been. And so when I pulled this case, I started thinking, why is it? I like to kind of try and figure out why, when I'm in a practice, why I'm seeing certain things. Like in Vegas, I saw a bunch of cocci. That makes sense. It's kind of the, desert Southwest. You see a lot of coccidioides there. You see different things in different areas. And here I just see a bunch of melanomas. And so I actually started looking into it a little bit more recently. And I wanted to kind of go over, this is the CDC data from about a decade ago. And Oregon, this state that we're in, has one of the highest incidence rates of melanoma in the entire country. It's like usually top 10, top 5, depending on where you look. You wouldn't necessarily think about it, but it actually makes sense because we're often a cloudy area. People think, oh, well, you can't get skin cancer if it's cloudy and they don't wear sunblock, but actually the UV rays obviously go through the clouds, so that's not indicative of your risk of melanoma by, being in a cloudy area. The other thing to think about is who gets melanoma besides people that are exposed to the sun? Old white people. And those are all states that have a lot of old white people. In fact, where I'm in Coos County, we have a lot of old people. When you look at our percentage of people over the age of 60, it's 36%. That's a high number of people that are elderly. Our median age is 48.6, and most of the people in our county are white. Now, compare it to the county that you're in, the years, it's a full 10-year median age below, and only 21% are over the age of 60. So who else gets melanoma? People that are outside a lot, have a lot of UV exposure. Well, Coos County is a very blue-collar, working-class county where we have a lot of people that work outside in the lumber industry. Bandon, where I live, the town I live, has a lot of cranberry bogs, so people are working outside a lot. So you get these older white men working outside, not wearing sunblock. This isn't the demographic. These blue-collar MAGA guys, they don't wear sunblock. This isn't Bend with your millennial young mom, wake up, do Pilates and yoga, put their skin routine on, go outside with their babies and their joggers and run around the river. I mean, we are like, kind of blue collar. They don't know what body wash is. These are old men that use bar soap. There's no such thing as a loofah in Coos County. So this is like a blue collar area. We are a high setup for melanoma. And I think that's why I see melanoma. One of the reasons why I see melanoma so much as such a big percentage of my practice here. So getting back to some other slides to kind of go over the differential of what this looked like in the head and neck. This was a case I had just a couple months later. And this is another neck mass in someone with no history. So this is also kind of a solid looking tumor, very plasmacytoid. Let me look a little higher. Very plasmacytoid, somewhat more cohesive, maybe not. It looks like it's a little more nested. It has a very prominent sclerotic vascular background. So you could be thinking of renal cell carcinoma, certainly low NC ratio, but even for renal cell, these are very bland nuclei. You can't really see the chromatin very well, but these are very bland, very round, no nuclear regularity. You could think about melanoma. You could think about in the head and neck, you have to think about metastatic medullary carcinoma from the thyroid with something like this, paraganglioma. Those are all things you think about. So then here is the synaptophysin, which is strongly diffusely positive. So synaptophysin, does that mean it's a neuroendocrine tumor? Does it mean it's a neuroendocrine, like well-differentiated neuroendocrine tumor? Could it be medullary? Could it be paraganglioma? All of those are still in the differential. What the next thing you have to do is a keratin stain. So this is CKA1A3, and it's dead negative. If this was a well-differentiated neuroendocrine tumor or a metastatic medullary carcinoma, this should be positive. So having a synaptophysin positive tumor that's keratin negative with this morphology is paraganglioma. And just to kind of show you, I've talked about this before, especially in the setting of bladder paragangliomas, these are GATA3 positive. So, like I've told you before, when GATA3 came out, it's like, oh, it's specific for urothelial and breast. Well, trophoblastic tumors are positive, and paraganglioma, pheochromocytoma are positive. So if you get this in the bladder, and it looks like a nested urothelial carcinoma, and you get GATA3 thinking you're confirming it, it could be a paraganglioma, which is very different, obviously, prognostically. So even the ones in the head and neck are positive. This is calcitonin, obviously a big thing to rule out as metastatic medullary carcinoma. This tumor also had intranuclear inclusions. Medullary carcinomas are thyroid tumors in addition to papillary carcinoma that have intranuclear inclusions. So in the setting of a thyroid tumor with intranuclear inclusions, it doesn't mean that it's a papillary carcinoma because medullary ones do too. Now, medullary carcinoma would be positive for keratin. This was negative, but calcitonin, I got it up front, and it's negative as well, just because that wasn't my differential on the H&E. So I usually, because it takes me a day to get my stains, I kind of throw them all out, my whole differential, rather than doing it in a stepwise approach, which isn't the most cost-efficient way to do it, but it's the best for, I think, turnaround time, getting a patient and the clinician a timely result. Now, this is S100. A lot of people talk about these sustentacular cells. Here you can kind of see that. But usually I find this S100 in paragangliomas, pheochromocytomas very disappointing. That area looks good, but then the rest of this isn't that great. Maybe there's one little area. That I don't see anything. This I don't see anything. Maybe here, but here I don't see anything. So, I don't really need an S100 to show the sustentacular cells, because even when you get it, it usually doesn't even show them that well. So, and then for paragangliomas, they are one of the most common tumors in the body that are associated with germline mutations, about 40 to 50% of them. And so when you get a paraganglioma and you diagnose it, you have to call the clinician and say, this patient needs a genetic workup. You need to send them to a genetic counselor. But what we can do on our part is do SDH, because a lot of these are SDH germline mutations. And so you should see loss of SDHB, which corresponds to all of the ones A through D. And this was strongly positive, so this was intact. So this patient does not have an SDH mutation. Now, SDH mutations in the setting of paragangliomas aren't always germline. You can have that with Carney's triad, where they get the paragangliomas, the GIST, and the pulmonary chondromas. But this is intact, but they can also be, VHL, von Hippel-Lindau, they get paragangliomas, neurofibromatosis, they get paragangliomas, MEN2A with RET, they get paragangliomas, pheochromocytomas. So I couldn't really do much more with that. All right, the next case.
Hey, sorry, Paul.
Yeah.
For the first case with the melanoma, there were so many plasma cells in there. Does that mean anything?
No.
Okay.
So a lot of metastatic malignancies to lymph nodes can have a lot of plasma cells if you like go back and look. So it was kind of a red herring in this case, but it's not indicative of anything else. Maybe an immune response, that's why I
Hmm.
think a lot of the immune kind of new chemotherapeutic drugs are so successful for melanoma. So maybe it has some sort of immune meaning, but it doesn't really mean anything as far as pathologically speaking, like it's a hint or anything like that.
Okay, thanks.
Yeah. This was a case I had in the state that shall not be named, where this is a neuro case. This was an ocular tumor where the neurosurgeon took this out. And this was a neurosurgeon who used to come and chat with me all the time. So he would break scrub, come and like sit in my office while we were waiting for the frozen. We would just chat. Um, so I always did my own scrape preps because I didn't like the way the PAs did them. They usually come out shitty, like a elephant smashed something and I couldn't see anything. And since I'm a cytopathologist, I want to see the cytology good. And so I would do my own kind of smears, and I always get them first, obviously, because it's faster than a frozen. And I was looking at this, and he was sitting in my office, and he actually had two other like residents with him. And I looked at this, and it's an ocular tumor, and I said, now these look like plasma cells. They have the clock face chromatin, really rounded nuclei, but then some bigger ones, but very plasma cell looking. And so I said, oh, I think this could be a plasmacytoma. And it's ocular, head and neck. That's the most common site for extramedullary plasmacytomas. And he said, that's ridiculous. He said, this guy's had this for at least 3 years. There's no plasmacytoma that would be there and not grown for 3 years. And that's probably true. And so I've thought, okay, well, what other plasmacytoid things would be in the head and neck and in behind the eye? Not a meningioma, not any sort of glial thing. And I thought, oh, well, maybe it's a paraganglioma. You get this really spotty atypia like neuroendocrine tumors, like Fio's, paragangliomas do that. And I said, well, maybe it's a paraganglioma. And he said, now that makes more sense. And so I signed out the frozen like plasmacytoid lesion or something like that. And it didn't matter. He had already taken out a huge chunk. He wasn't going to go back and do any more. He just was kind of curious. And then this was the permanent that came out. And this was a plasmacytoma. So he was wrong. It had not been there for a few years. The patient had said that, but these patients get shit wrong all the time. So you have to really be careful about taking too much credence into something that they say. You definitely have to listen to them, but ultimately you have to make your own decisions. So this actually was an extramedullary plasmacytoma. They are less common than the bone plasmacytomas. About 20 to 50% of the time, they'll have an associated M protein, even if you don't have myeloma. So that can be helpful if you're working something up and it's taking you a while and you tell the clinician they may want to, get an SPEP in the meantime. And that's exactly what happened in this case. This is a case I had at the end of last year. And this was a lung tumor. The person had multiple lung lesions and supposedly a tumor in their head and neck, cavernous sinus. They had thought that it was a meningioma, but then they looked more at it and they're like, no, actually, maybe it's malignant. So this is a lung core, and this is very plasmacytoid. Um, and again, I kind of thought maybe this is a plasmacytoma. It's very plasmacytoid. Some of it's, even bigger than that, but I thought it was very discohesive, very plasmacytoid. Again, I had a huge differential, melanoma. Look at that big nucleolus. This could be melanoma. This could be anything, carcinoma. So I call the clinician. I told you usually what I do is I'll call clinicians when I get a weird case, and I'll tell them, hey, this is what I'm thinking. Does the patient have any history? And in this case, I said, does the patient have any history? No, no history, no, nothing, just this cavernous sinus thing. And I said, one of the things in my differential is a plasmacytoma or, manifestation of myeloma. See how it's getting even kind of amphiphilic here? That's a good kind of plasma cell look. I think this doesn't look that dissimilar from that weird plasmacytoma I just showed you. And so I said, you know what, get an SPEP, get this, get that, let's work it up clinically and pathologically at the same time. So here's my CD138. Now this time, these tumor cells are positive. And the point about this is that, as I've mentioned before, CD138 is not specific for plasma cells. It stains them, but it also stains carcinomas, in particular, aggressive carcinomas. The more aggressive a carcinoma is, the more likely it's going to be CD138 positive. So that can really play with you. And in this case, I knew that, but I still saw the CD138, and the kappa and lambda were negative. And so thankfully I'd gotten other stains. Here's CKA1A3. So now we have CKA1A3. The type 2 pneumocytes of the lung are positive. The tumor is negative. So you have a CD138 positive, keratin negative tumor. So that absolutely could be a plasma cell neoplasm. But like I told you, get 2 keratins. This is actually PAX8. PAX8 is strongly positive. So does that mean that it's not hematopoietic? Not at all. PAX8 can actually be positive in B cells. It's kind of homologous to PAX5, which is obviously a B cell marker. So I've almost made this mistake before, where I had a splenic tumor that was PAX8 positive and everything else was negative. And I called a clinician who was a very good oncologist, and I told him, hey, maybe this is like a renal cell. He's like, number 1, 2, and 3 in my differential were a lymphoma, like a diffuse large B-cell lymphoma. So I started reading, and I saw PAX8 can be positive in B-cell lymphomas. And that case ended up being a B-cell lymphoma, a diffuse large B-cell. So PAX8 doesn't really help in this case. And then I did CAM 5.2. Because I always do 2 keratins, and that is strongly positive. So CD138 positive, PAX8 positive, GATA3 was positive, I think, and CAM 5.2. So what the fuck is this? I had no idea. It wasn't positive for anything else. So I kind of worked it up a little bit more. Let's see. I signed it out as a malignant tumor with plasmacytoid and rhabdoid features, most consistent with metastatic poorly differentiated non-small cell carcinoma. I saw that he had a cavernous sinus mass, which is what I mentioned. And I said in the setting of a big cavernous sinus mass with innumerable lung nodules, it's possible that that's the primary, and these are Mets, but this is a weird immunophenotype. And so I actually sent it out for cancer type ID. And at the same time, by the time I signed this out, the SPEP had come back negative. They had done a bone marrow biopsy, and that had come back negative for myeloma. So then here is the cancer type ID. It came back as melanoma. This is not melanoma. Notice that this is a 90% probability. When those are under, with this particular test, with a 90% probability, that is not a high probability. For this test to be really suspicious for whatever they think, it needs to be like over 95, 97, 98. Then you can rely on it. This do not rely on. This is not melanoma. No way that this was melanoma. When I went back in preparation for this, I started reading more about this, and I'm pretty sure I screwed this case up. The patient ended up dying before this came back. So it didn't matter what this was going to end up being. She went on hospice immediately, and so it didn't really matter. But I think, in retrospect, that this is actually a SMARCB1 deficient carcinoma. This is something that kind of came more to fruition when I was out of residency. This is all kind of new, and so I'm not as proficient and comfortable with these because I don't really see them, or if I see them, I'm missing them, like this case. But these are tumors that are often plasmacytoid or rhabdoid. They are sinonasal, so this was in the sinus cavity. They are very aggressive, so that would make sense. I think that in retrospect, that's probably what this was. I actually went back to get the block a week ago or a couple weeks ago when I pulled these cases to show you guys to get an INI1, and there's nothing left in the block, so I couldn't do it. But I was gonna do it, and even though she's dead, I thought it would be, interesting to kind of diagnose that but I think that that's what this was. This is not a melanoma. This was wrong. All right, so that was a long time for case 1. Case 2 is going to be faster. So case 2 is a 61-year-old guy, history of diabetes, non-healing foot ulcer, underwent a CAT scan, saw a 4.8 centimeter mass in the left upper pole of the kidney. So they did a radical nephrectomy because it was too big and involving too many structures to do a partial nephrectomy. And so here's the tumor. The tumor is not a diagnostic dilemma. So anything clear, you want to think about, it's usually clear cell carcinoma. That's obviously more common. Could it be a clear cell papillary renal cell tumor? Those are common. I don't see any tubules. You don't see any polarization. So probably not that. Those are often smaller. Chromophobe renal cell carcinoma can look kind of clear, but this doesn't really look like that. So this is a clear cell renal cell carcinoma, nuclear grade 3. Here we're at 10x, and you can see some nucleoli pretty easily at 10x. So this is a nuclear grade 3. The interesting thing with this case is what was in the kidney around it. So, part of the guidelines when you do these CAP templates is you have to evaluate the non-neoplastic kidney. And this non-neoplastic kidney has tons of granulomas. So what is this? Is this a granulomatous interstitial nephritis? Technically, yes. That's what this is. But is it because of the kidney tumor, or is it an underlying disease that the patient has? Here you see some globally sclerotic glomeruli, and the interstitium is filled with these non-necrotizing granulomas. And so I thought this case was interesting because I started looking in the literature, and there are tons of articles about renal cell carcinoma associated with a sarcoid-like reaction in the kidney. And it's interesting because you can think of this one of two ways. Maybe this patient had sarcoidosis. It's an older man, probably not. The other thing is maybe he had sarcoidosis and that predisposed him to get a renal cell carcinoma, or is this renal cell carcinoma causing a sarcoid granulomatous-like reaction? We know that Hodgkin's lymphoma, seminomas, they cause granulomatous reactions, and renal cell carcinoma, particularly clear cell type, apparently does the same thing. In fact, there's this one where the patient had a multi-organ sarcoid-like reaction, and then it went away when they took out the patient's renal cell carcinoma. So it's just kind of a reminder to make sure you take a look at the remainder of the kidney, because you can always see really interesting things. In this case, it probably has no clinical impact or implication on the patient, but sometimes it does. This is another case I had when I was back in Las Vegas. Another case where it's just a typical clear cell renal cell carcinoma. And then when you look at the kidney parenchyma adjacent to it, now what you do is you don't want to look right close to the kidney, because in fact, they recommend that you have at least 5 millimeters of non-neoplastic kidney in order to evaluate the non-neoplastic renal parenchyma, because adjacent to a capsule or pseudocapsule, you're always going to get globally sclerotic glomeruli, tubular atrophy, interstitial fibrosis. You want to go far away to really evaluate. And then what are the diseases that you see in the kidneys most often in these settings? Well, most common is like arterionephrosclerosis or hypertensive vascular disease. That's the most common. Second most common is diabetic glomerulosclerosis, Kimmel-Still-Wilson nodules, etc. This was a case where this looked like there are globally sclerotic glomeruli. We're kind of far away. But to me, I think that this looked like there's some sort of homogeneous pink material in here, and this isn't just fibrosis. And then when you get to other glomeruli, you don't need EM to see that these membranes are markedly thickened in areas. And this is actually amyloidosis causing a membranous glomerulonephritis. And so you really have to look at these cases because you can't be expected as a private practice or even a general academic pathologist to make this diagnosis. But what you can do is identify that something's wrong. This is, some sort of underlying kidney disease, and then send it to a renal pathologist to work up. See, this is membranous glomerulonephritis associated with deposition of AL amyloid. So in this case, the amyloidosis had nothing to do with the renal cell carcinoma. It was completely incidental. Other big renal diseases that you get associated with that are most often seen are like thrombotic microangiopathy, focal segmental glomerulosclerosis, IgA nephropathy. So you have to kind of be aware to look for these. Again, when you have a partial nephrectomy, which we're seeing more and more now than we ever did 20 years ago, you have to be very careful because you don't usually have 5 millimeters of renal parenchyma to evaluate, and you want to be very careful about evaluating that parenchyma immediately adjacent like you would see in a partial nephrectomy. So then the other things to look for, let's talk about other incidental things you see in the kidney when you have a renal cell carcinoma. So you always want to go through, and it's really easy to fall into the trap when you have a nephrectomy that you're grossing of looking at the tumor, sectioning the tumor, looking at margins, looking at renal vein margins, renal pelvis, etc. And then the rest of the kidney, you're like, a centimeter, you section it 1 or 2 centimeters away, in sections, and you don't really look that carefully. Look carefully. This is a case of a patient that had a papillary renal cell carcinoma, and then they had multiple other nodules in their kidney. Here's one. This is about 5 millimeters in size. This patient had a papillary renal cell, like I said, kind of the conventional type. And then this looks like papillary renal cell, but it's under 15 millimeters. If it's 15 millimeters or under, and it looks like a papillary renal cell carcinoma, that's a papillary adenoma. They can have pseumomatous calcifications. They have these clusters of foamy macrophages. So there's one. There's a little bit of normal kidney. Here's another one. And then here's another one in another section. And then another one. These are usually cortical based. They're not in the medulla. They're by definition 15 millimeters under. I think back in 2015 that changed. It used to be 5 millimeters or under. It was a papillary adenoma. Anything over was a renal cell. But then they realized that anything 15 millimeters or under that had that same morphology doesn't really do anything. It has almost no malignant risk, kind of like NIFT-P. And so they changed the criteria to 15 millimeters with the newest WHO. So although a lot of people can have multiple papillary renal adenomas or just renal adenomas, when you have multiple of them, you need to think about hereditary papillary renal cell carcinoma syndrome. The only way to diagnose this is in kidneys. These patients don't get other tumors like, FH deficiency. They get the hereditary leiomyomatosis, so they'll get the skin leiomyomas. They'll get the uterine. Women will get uterine leiomyomas. They present early, and then they have the FH deficient renal cell carcinomas, which are also kind of papillary looking, but very aggressive, not low nuclear grade like these. And so, but this is they only have kidney manifestations. It's autosomal dominant. It's associated with MET, which is MET, germline mutation. And so that's something that they would need genetic testing for because, if they get another kidney, because these patients get bilateral kidney tumors. So if you already do a radical nephrectomy, can't do a radical nephrectomy on the other side because then they won't have kidneys unless you give them a transplant. So they should opt for doing partial nephrectomies and following them very closely. So the other tumor that you see, that I've seen incidentally quite a bit, is something that I'm going to show you here. Now this is a chromophobe renal cell carcinoma. So this is a very good chromophobe where you get this very plant-like, coilocytic nuclei, perinuclear halos. Usually have grade 3 nuclei, but here you see these really good perinuclear halos, very coilocytic looking nuclei, very prominent cell membranes. So chromophobe's the third most common renal cell. What I just showed you, papillary renal cell carcinoma, is the second most common. Obviously, clear cell is the first. But in this case, I saw this tumor, and this one is not in the cortex like renal adenomas. This is in the medulla. And this is something called a renomedullary interstitial tumor. They used to be called medullary fibromas, and they used to think that this was amyloid. It's not. It's just like keloidal scar. They often entrap surrounding renal tubules. It's very keloidal looking, often myxoid looking. These are bland. These have no malignant risk whatsoever. But it's something just to look for. It means really nothing, but a lot of people have these. Autopsy studies find a ton of these. Same with renal adenomas. You know, renal adenomas, you have to be careful because those are often seen in the setting of chronic renal disease. And patients that have chronic renal disease also are more likely to get papillary renal cell. They also get clear cell papillary renal cell tumors more often and other renal cell carcinomas more often. So just because you have multiple papillary or renal adenomas in the setting of papillary renal cell doesn't mean that it's a hereditary germline mutation. And this is just a benign kind of incidental thing. It's always a pretty tumor. I like showing them. But again, you can see why they used to think this was amyloid. It looks kind of amyloid-like, not without the cracking, but it entraps these tubules at the periphery. All right, let's move on.
Hey, Paul, I got a quick question.
Yeah.
Did they notice anything grossly on the incidental finding of the potential syndrome?
So yeah, that was my case, and I sampled it because there were a ton. I was in residency, and I sampled it because there were a ton of little nodules. Now that syndrome had not been recognized then. This was in 2002, I think.
Yeah.
And so, but we knew that there was something. We didn't know the gene, but that's probably what that was in retrospect.
Yeah, it was kind of interesting. Like one of my autopsies at UCLA with the younger fish fry, we saw like hundreds of these small little nodules, but then it became like a bioethical question if they should do germline testing, because then you're gonna have to tell like the next of kin because we noticed it on autopsy. Yeah, just reminded me of that case.
Yeah.
Very interesting. Thanks for sharing.
Yeah. Yeah, I think you would. That's the whole point of an autopsy. Is these patients, a lot of times, when I've talked to family members, because in private practice, you call the family when you're going to do an autopsy because they're the ones ordering it usually. And so I call the family, and the number one, the biggest concern is there any reason why this patient would have died? Like my husband, my wife, my son, whatever, that could have implications for me, or a lot of times they want to know if they missed something, but a lot of times they want to know, he died so suddenly. Is that something that is running in the family? So I would think most of the time you would want to make that diagnosis, even post-mortem. Okay, anyway, case 3, 84-year-old guy, no known prior history, that's important, presented with blood in the stool and associated anemia. They did a colonoscopy. There were over 100 polyps scattered throughout the colon. Multiple biopsies were performed. When you hear that, and that there's multiple colon polyps, and it's someone who's 84. So, I mean, the two big things in the differential would be FAP, but an 84-year-old who had a colonoscopy before, it would not be that. And then when you see what looks like lymphoid big aggregates, it's only one entity. Anybody want to say what that is? Max, get off of mute and tell me what this is.
Diffuse large B-cell lymphoma versus mantle cell.
But what's the name of this presentation? Hundreds of polyps that look like lymphoma.
Lymphomatosis
It's called
coli?
lymphomatous polyposis.
Lymphomatous polyposis, yeah.
And if you know it's lymphomatous polyposis, then it helps you say what it is, because it's almost always mantle cell lymphoma. But this is different. Why is this different? What else is here? What is this pink material? When you see a lymphoma and you have pink material, it's either sclerosis or it's this.
Amyloid.
Yes, there's a ton of amyloid. So then what lymphomas give you amyloid? Usually it's a malt lymphoma or lymphoplasmacytic lymphoma, like people with Waldenstrom's. There was a ton of amyloid all over this tumor, everywhere. And that was the thing that was most striking to me. And I'm like, okay, well, mantle cell lymphomas, I didn't know that they can have amyloid or significant plasmacytic differentiation. And is this really amyloid? So this patient had multiple polyps. And here is the Congo red, and it is orange. And I can tell you there is green birefringence. This is amyloid. This is an amyloid-producing lymphoma, and it looks low nuclear grade. It doesn't look like something, and diffuse large B-cell lymphoma wouldn't present with lymphomatous polyposis. That would have like a big mass. So then let's look at the nuclei, and they are a little convoluted, but they're mostly round. So then what is this? Obviously, we have to do stains, but when you think about the actual what this usually is, most of the time, like I said, it's mantle cell lymphoma, but sometimes it's actually follicular lymphoma. So, but what about marginal zone lymphoma? Because I was thinking, well, this is kind of all the amyloid. I usually think about a marginal zone lymphoma in the colon or the GI tract. You think of the most common lymphoma is a marginal zone lymphoma, extranodal marginal zone or malt lymphoma. And so I started reading, and there have been descriptions of marginal zone B-cell lymphoma of the GI tract presenting as lymphomatoid polyposis or lymphomatous polyposis. People use those interchangeably. And so I thought, well, let me work this up and see what the immunostains show. So here is CD20. I can't imagine a T-cell lymphoma ever giving you this. I can't imagine, there's nothing benign or reactive that would be this. So CD20 is strongly positive, so this is a B-cell lymphoma. Here is CD3. So obviously CD3, I always used to think, oh, it's such a waste to do CD3. It's not going to be CD3 positive. But it's really helpful when deciding if there's co-expression of T-cell markers. So this is a good idea that this is CD3, knowing that there's hardly any T cells. And then here's CD43. CD43 is usually a T cell marker. It's very helpful in stomach marginal zone lymphomas because a lot of times you don't get any other hit, or you can't get kappa lambda light restriction because there aren't many plasma cells. And so doing this is very helpful because if you have CD43 co-expression of a B cell proliferation, it's a low-grade lymphoma, or it's a lymphoma, I should say. It's a B cell lymphoma. So this, I was thinking, okay, well, I know it's a B-cell lymphoma. Now this kind of confirms it's a B-cell lymphoma. Now, what kind is it? So here is CD138 because there's all that amyloid, and there is a lot of plasmacytic differentiation here. These are the actual lymphoma cells, not plasma cells. So there is a lot of plasmacytic differentiation to this lymphoma, which is not it's not exclusionary to only a marginal zone lymphoma or lymphoplasmacytic lymphoma. And then just to show you, it is kappa and lambda helpful here. Kappa-ish, you can see the background plasma cells in the lamina propria are positive. The tumor is negative. And here's lambda. The tumor is positive. So there's a lambda-restricted B-cell lymphoma. So now what kind of lymphoma is it? So CD10 was negative, and here's CD5. You remember what CD3 looked like. So CD5 is co-expressed on the B cells. So now it could be a CD5 positive follicular lymphoma, but CD10 was negative, so that would be weird. It could be a mantle cell lymphoma or CLL. So we know this is a lymphomatous polyposis. It's probably mantle cell. Here's cyclin D1. And SOX11 was positive also. So this is a mantle cell lymphoma with plasmacytic differentiation. I had never really heard of that. It's supposed to be rare outside of lymphoplasmacytic lymphoma and marginal zone lymphoma. So I started, like what I do is I went to the literature, and I first went to the WHO, and under mantle cell lymphoma, they do talk about plasmacytic differentiation with mature light chain restricted plasma cells can rarely occur. And then I went to the literature and I found evidence of patients that had amyloidosis or what looked like amyloid deposition in the setting of a GI mantle cell lymphoma, the GI tract. There were 3 cases in this series, and one of them was in the GI tract. So I told the clinician that that's what it was, and he's like, "Oh, that's really interesting. I knew it had to be something weird." And then he went to the patient, and he said, "Oh, you have something that's called mantle cell lymphoma." And the patient's like, "Oh yeah, I knew I had mantle cell lymphoma. I had it like 10 years ago, but it went away and nothing ever happened with it." So, and he had just moved to Oregon. He had retired here. It's like, Jesus, like it would have saved me all this time, all this literature search I did if he just told me he had mantle cell lymphoma. Most patients with lymphomatous or lymphomatoid papula or polyposis, that's whether it's mantle cell or follicular or whatever, that's the primary presentation. It's rare that they actually have a history of that lymphoma that then secondarily involves the GI tract. So this was a really unusual tumor or presentation for multiple reasons. Now, here's another case. This is a GI polyps that I had where there's one sessile serrated lesion, and then you have one tubular adenoma, and then this polyp was a big lymphoid aggregate, which is too big. And this is one I worked up, and this actually was a marginal zone lymphoma. This is a malt lymphoma. And just to show you in comparison to the other cytology, malt lymphomas typically have much rounder nuclei. Mantle cell lymphomas are known to have a little more convoluted nuclei, not quite as much as follicular lymphomas, but marginal zone lymphomas are typically much more round and regular like this one. So this was actually ended up being a malt lymphoma of the colon, which is uncommon. Normally you see them in the stomach. It's one of the most common. It is the most common lymphoma in the stomach. And it's often associated with H. pylori. They don't have that same association in the colon. And then when you're thinking about peritumoral amyloid, it's not always lymphomas. This was a duodenal tumor that I had. What does this look like? This looks like a classic neuroendocrine tumor with this kind of trabecular acinar arrangement. The nuclei are really classic salt and pepper nuclei. This was a grade 1 well-differentiated neuroendocrine tumor of the duodenum. And in addition to being this, it had tons of amyloid that's associated with tons of foreign body giant cells. Here you really see that cracking of amyloid really well. A kind of smudgy, cloudy look, lots of giant cells. So when you see amyloid in the setting of a well-differentiated neuroendocrine tumor, if it's in the pancreas, it's more likely an insulinoma. Those often behave in a more benign fashion. If it's in the duodenum, which this one is, it's often a somatostatin secreting or producing tumor. There's really nothing that we did for this to try and prove that. It's just kind of in the literature, that's usually what these are. If you see amyloid in the setting of a well-differentiated neuroendocrine tumor in the duodenum, it's usually somatostatin producing, and that's what gives it that amyloid deposition. All right, last case. So this is a 45-year-old woman. She had a multinodular goiter, 4.2 centimeter right inferior thyroid mass. I'll tell you while I'm focusing on that. She had preoperative FNA of multiple nodules. They were all benign, but the largest one in that right inferior was acellular or unsatisfactory, and so they did a right hemithyroidectomy, and the ENT sent it for frozen section. I hate doing frozens on thyroids. I usually do a smear and look at cytology. I do not freeze them. Why are they doing a frozen section when they did preoperative FNA? A couple reasons. One is it was unsatisfactory. But even if it was benign, they will often, if it's over 4 centimeters, send that for frozen. They want you to freeze at any nodule over 4 centimeters, because if it's papillary carcinoma, then they'll do more surgery, lymph node dissection, etc., take out the other thyroid lobe. And so that is why she sent it for frozen. Thankfully, I did not get this frozen because I guarantee you I would have fucked this case up. So my colleague got this case and he showed me the next morning and he came and he said, hey, look at this thyroid I got. It was really weird. He said, you got the FNAs, the others are benign. This one was unsat. And I started looking, I'm like, this is very, very spindled. It's like almost purely spindled. So 95% of the time, maybe even more than that, when you have a bland, and it's bland, it's cellular, but it's not that cellular, and there's not a lot of atypia. You know, it's frozen section, so everything's going to look hollowed out. That's what I was telling you about the intranuclear inclusions. These are not intranuclear inclusions because it's all hollowed out. This is just a, you know, frozen section like ice crystal artifact. But when you have a bland spindle cell lesion of the thyroid, it is almost always medullary carcinoma. And so then you're like, okay, well, what else gets amyloid besides what I was talking about? Medullary carcinomas get amyloid. So then you start looking for amyloid or anything that kind of looks like it. And there really weren't any great areas on the frozen that I saw, but this was just so uniformly bland. But then there were rare areas at the periphery where this spindle stuff kind of merged with kind of more trabecular, rounded, cohesive, follicular looking groups. So that doesn't rule out medullary carcinoma because medullary carcinoma can involve adjacent thyroid parenchyma and surround it and make it look like it's part of the tumor. I've been fooled by that before. And so I didn't know if that's what was going on, but this really looked like a merging rather than involving it. See, that all looks kind of cohesive, like follicular. And then you kind of merge into this spindled stuff. So I don't know what I would have called this on a frozen, honestly, but I was really thinking it was a medullary carcinoma. And then here's the permanent, and I thought, yeah, I do think this is medullary. This looks like it could be amyloid. I can't tell. But it looks kind of pink, vascular. This could be amyloid. It's spindled, a little epithelioid, kind of plasmacytoid. This really looks like medullary carcinoma. But then again, when you got to the periphery, it looked different. It looked more like follicular, almost parathyroid-ish. Looks like it's, you know, this does not necessarily look like medullary carcinoma. Even the plasmacytoid look of medullary, this looks follicular. So then we did a bunch of stains. And here is TTF1. So TTF1 is positive. Does that mean it's not medullary? Not at all. Medullary carcinomas are TTF1 positive. They usually are variable, like weak and strong and weak and strong. This is diffusely strongly positive. You can see it's really positive in that follicular looking area, that trabecular, but it's also positive in this spindled area, and it's strong. So that would be a little weird. What this does tell us is it's not a spindled anaplastic carcinoma. It doesn't cytologically look like one anyway, but that's the other big spindle cell tumor that you get in the thyroid is an anaplastic carcinoma. And then also there's settle, which is spindle epithelial tumor with thymus-like differentiation. Those are biphasic tumors. They're usually in kids or young adults. Doesn't make sense for this at all. The other thing that's weird about this for medullary carcinoma that I focused on is this was in the inferior part of the thyroid. Medullary carcinomas are usually at the junction between the mid and superior or superior lobe of the thyroid because that's where all the C cells embryologically are. Those parafollicular cells that Hertel first described and that we ended up calling Hertel cells, oncocytic cells, which they were actually parafollicular or C cells. Those are in the upper thyroid. So most medullary carcinomas are going to be upper thyroid or upper to mid thyroid, not inferior thyroid. So that was another soft thing that I didn't really think about at the time. Maybe I should have, but it didn't really matter. Thankfully, I didn't call this medullary carcinoma on a frozen, and neither did my colleague. He just kind of deferred. So TTF1 kind of favors, it tells you it's not anaplastic carcinoma. Here's thyroglobulin. So thyroglobulin would be negative in medullary carcinoma, positive in follicular tumors. So it's negative, but not really. When you get out to the periphery, and again, is this entrapped? Is this part of the tumor? It actually is weakly positive. And it gets even more so when you get even further out into the more follicular looking areas. Look at that. So is that involved? Is that part of the tumor? It really looks like part of the tumor. And even some of the tumor cells that are spindled have a little bit. So then, oh, what the hell is this? So now here's synaptophysin. Dead negative. So this is not medullary carcinoma. It's TTF1 positive, synaptophysin negative. Just to be sure, we did calcitonin also. Calcitonin is positive in 95% of these. Also, serum calcitonin is also positive in patients with these big medullary carcinomas, like CEA also. Calcitonin is negative. So this is a TTF1 positive, thyroglobulin positive-ish tumor, spindle of the thyroid. So we ended up thinking this is probably a spindle cell metaplasia, like extensive spindle cell metaplasia of follicular adenoma. But because it's so weird, we ended up sending it out to Bruce Wenig, who is at Moffitt, who's like a famous head and neck pathologist. I've loved his atlases throughout the years. And he said the same thing, follicular thyroid adenoma with spindle cell metaplasia. And he noted that these can occur spontaneously, this metaplasia, or it can occur following a traumatic event such as an FNA. So who knows if it was because of the FNA or if it was like that already. But either way, it's a really, really interesting case. So just to show you an actual spindled medullary carcinoma, these can look really similar, where you have these kind of bland spindle cells, and this is amyloid in this case. And this one is diffusely spindled. It doesn't have to have spindled and polygonal or plasmacytoid, but then when you have these actual medullary carcinomas and you look on high magnification, they have that classic neuroendocrine stippled chromatin pattern. And again, remember, you can get intranuclear inclusions in medullary carcinomas. That doesn't mean it's some sort of spindled papillary carcinoma. Here you have good amyloid next to the spindle tumor. So most of the time that you see these spindled tumors or significantly spindled tumors in the thyroid, they're going to be medullary carcinomas. And then again, you can't forget about a really atypical spindle cell tumor like this one, where you have lots of necrosis, and then you've got these really atypical spindle cells where you start seeing lots of mitotic activity, very atypical spindle cells. Sometimes you'll see squamous differentiation. You can see metaplastic, like mesenchymal, like chondroid, muscle, bone. This is an anaplastic or undifferentiated thyroid carcinoma. These can mimic any other sarcoma in the thyroid. These are usually elderly patients. The thing you really want to do when you have these is sample the tumor. Go back, if you don't have any pre-existing tumor on your slides, go back and really sample them, because these usually, although not always, come from some underlying well-differentiated or even poorly differentiated follicular derived tumor, like a follicular carcinoma or papillary carcinoma. I would say about half or 2/3 of the ones that I've seen in my career, on first glance, on my first sectioning, I've seen papillary carcinoma or underlying follicular carcinoma. So that kind of takes away from the having to work it up for a primary thyroid or head and neck sarcoma. All right, that's it. So any questions from any of you?
Well, for that last case,
Yeah.
could a hyalinizing trabecular tumor look kind of like this?
No.
Yeah. Okay.
No, I mean, those are, you would have the sclerosis, but they're usually not spindled, and they have that, they're very polarized looking. They do have a lot of inclusions. They have more papillary thyroid-like nuclei. They're also usually really small.
Yeah.
They have a lot of calcifications. So although they have, their nuclei are more elongated, I wouldn't say that they're necessarily spindled. If that makes sense.
Yeah, no, I mean, the photos I'm seeing aren't really that spindled. I'm wondering if there was a weird flavor I didn't know about.
Yeah, not that I'm aware of.
Cool.
How often do you get typing of the amyloid? Do you do it at the request of the clinician, or do you
Yeah,
ever
and you
do
know,
it yourself?
I don't. I mean, I have done it rarely. I usually don't get asked for that, and it's surprising because that's become such a thing um, that I almost never get asked for it. But yeah, I'm also not a hematopathologist, so I think a lot of times it's in that setting where they ask for it more often. But I can tell you, no doctor in Coos Bay is going to be asking me what kind of amyloid this is. But yeah, I would only do that at the request, and I usually don't. The cases that I have are usually amyloid in the setting of something else where you have a known etiology. So I don't know that it would really matter.
Yeah, that makes sense. Thanks.
Wow, I'm actually getting questions today. It's nice. All right, so my next one is Halloween. So I will see you in a little over a month.
Thank you.
All right, thanks.
Thanks, man.